Should we start?
Yeah, a very good afternoon to everyone. On behalf of IAP Central Delhi branch and BLK Center for Child Health, I, Dr. Swati, welcome you all to this BLK Telepedes webinar. We know that pediatric head trauma is a common emergency which is dealt in the emergency department. Most of them are mild, and we know that time is of the essence when we are dealing with such patients. So today we will see how to systematically approach a child with pediatric head trauma and how to identify those who need a multidisciplinary neurocritical care. For the discussion, we have with us Dr. Naresh Lal. He is Senior Consultant Pediatric Intensive Care at BLK Center for Child Health. Welcome, Dr. Naresh. And as panelists, we have with us Dr. Rachna Sharma. Ma'am is Senior Director, Pediatric Intensive Care at BLK Center for Child Health. Welcome, ma'am. Dr. Rohit Bansal, he is Director, Neurosurgery and Neurospine at BLK Center for Neurosciences. He'll join us shortly. Dr. Shashank Raj, he is a consultant in the Department of Radiology. He specializes in neuroradiology. Welcome, Dr. Shashank. And last but not the least, Dr. Rajni Farmanian, Principal Consultant, Pediatric Neurology at BLK Center for Child Health. Welcome, Dr. Rajni. Over to you, Dr. Naresh.
Yeah. Thank you, Dr. Swati, for this introduction. So today we will be discussing about pediatric head trauma. And as Dr. Swati has already told you that, yes, head injury per se is a very important topic to discuss because it is one of the commonest cause of mortality in children. And even in the census also, if you see the accidents and traumas are the most common cause of mortality in children up to 5 years of age. So children tend to get injured from a variety of mechanisms, and it also depends upon the age group of the children. So we know that the children are quite active. So the overall incidence of trauma and injuries are more common in the children, that in younger children, and as compared to the adults. So children can have various types of injuries, like they can fall from a height, like while climbing down, or they can have in infants also. There is very important abusive head trauma, so that's a different entity. And in case of older children, the commonest causes of injuries are motor vehicle accidents and sports. Because older children are more active and they're into sports, so that is also a common area where injuries are seen. So we have to understand that why children are more susceptible, and it is related to their body habitus and their physiology. So we understand that the kids have softer bones. They have a large head to body ratio. So the center of gravity is always towards the upper part of the body, and that is why they tend to fall often. And their neck musculature is also weak. So the head is not supported properly. The neck muscles are weak. So the acceleration and deceleration injuries, which can happen in high speed accidents, tends to affect children more. They have more water content in the brain. So that is why the injury chances are more in the infant and the younger children brain. And the skull, as you know, that it is soft. So overall, the injuries and the impact is felt more in children. So just some statistics. So as I said that the presentation age, there's a bimodal distribution. So for in the first 5 years of age, it is mostly because of falls. Infants and all, the mothers are carrying them in their hands, and sometimes we have seen they get slipped out from the hand and they fall. So falls are more common in up to 5 years of age, and in older children beyond 5 or 10 years of age, it is mostly because of motor vehicle accidents and sports. Males, it is the incidence of trauma in males is more because they are more active, and so we see more injury in case of males than in females. The overall mortality in pediatric TBI is somewhere around 3 to 6%, but in case of severe TBI, where especially there is a multi-organ injury or multi-system injury is there, in those cases the mortality can be very high, up to the tune of 30%. So that's a significant number. Regarding the symptoms of the head injury, the loss of consciousness is the commonest presenting symptom. So that is what the parents come, that the child has fallen while playing or while stairs and he was unconscious for some time. So that history has to be considered important. The duration of loss of consciousness is important. Loss of consciousness for a few seconds may not matter, but a prolonged loss of consciousness for an hour or so is significant. And if it is followed by vomiting, it is all the more significant. Alone, vomiting per se is not that specific, but LOC with vomiting is a significant sign. Children can also present with persistent headaches. They can present with irritability, drowsiness, confusion, and in extreme cases, seizures can occur. So that those are the red mark, hallmark signs. And if we see particularly the bleed in brain, then the type of bleed is also important when we encounter these patients. So we know that if it's a subdural hemorrhage, it is more like a abusive head trauma, like in case of small infants, shaken baby syndrome. And if you see EDH, the extradural hemorrhage, that is more common in case of older children. That is because of a direct trauma, maybe motor vehicle or maybe a sports injury. And if it's a diffuse bleeding everywhere, like subarachnoid hemorrhage, that means the mechanism of injury was very severe. So we can get some idea based upon our CT and MRI findings. So with this, I'll be discussing a few cases which we have managed in our PICUs, and we will try to learn how to manage these cases, because neuroprotective care in these patients with head injury is very, very important. So I'll emphasize on that as we progress. So let's see the case number one. This first child was a 4-year-old child. A very common scenario that the child fell from the stairs while stepping down. In this child, there was no loss of consciousness, but the child had one episode of vomiting after 10 minutes. The child was otherwise all right, and the parents were a little worried because the child was complaining of mild headache. So they got the child to the primary caregiver, the pediatrician, and they went to him, and the pediatrician saw the child, except for a mild hematoma on the right side of the head. The GCS was normal, and the child was fully conscious oriented. So in this case, Dr. Rachna, are you there?
हाँ जी डॉक्टर निश.
Yes, ma'am. So, ma'am, can you classify the severity of TBI injury in this child?
So this child looks like a case of mild head injury. Whenever we say it is mild, it is whatever classification there has been proposed for traumatic brain injury, that has been on the basis of Glasgow Coma Scale. We all know what is Glasgow Coma Scale. So whenever the GCS is between 13 to 15, we say that it is a minor head injury or mild head injury. However, whenever the GCS is between 9 to 12, then it is moderate, and anything which is less than 8 is considered to be very severe head injury.
So, next question will be a very obvious question, ma'am. The parents will be asking, should we do a CT scan for this child, ma'am?
Yeah, so I think this is a very important question, because I think we often come across such patients in the OPD as well as in the emergency at all odd hours, that the child had some injury, child had cried, child had breath hold, especially children who are of younger age group, and sometimes they vomit also. So here with a lot of data and evidence has come from the literature, that if you have a child whose GCS is less than 15, that is, one is that if the child has an altered mental status, then obviously you don't have to think about it. You're going to go ahead and do a CT scan. Or a child who has loss of consciousness for more than 5 minutes, amnesia for more than 5 minutes, child is looking disoriented, and child is vomiting. So vomiting, they say that if child is vomiting, has vomited more than 3 times, then yes, such a child we should do a CT scan. Now there are certain subtle, there are children now. See, one is altered mental status where you are doing it. Now there will be children who will be looking, you will be irritable, complaining of headache, and these are the children where it will be debated whether one should do a CT scan, or whether such children can be observed. So there are recommendations where such children can be observed for 4 to 6 hours instead of doing a CT scan. As we all know that once we are doing a CT scan, there is a lot of radiation exposure. So this evidence has come from the fact that sometimes the children will be fine. Plus, even the cases of concussion will come under the heading of mild head injury, and the patients with concussion will complain of headache, will complain of irritability, and the symptoms of concussion of 1 to 2 weeks before the children will be better. So if I look at it, look at the present scenario or the present situation which Dr. Naresh has presented, it looks like we can wait and we may defer CT scan. So again, I am reiterating one fact that taking a decision to do a CT scan depends upon three things. One is the clinical situation of the child. How are the parents, with how are they placed, whether they will be able to observe the child or not, and then obviously we have to see where they are living, where. So one has to decide whether we can observe or whether we need to do a CT outrightly, because doing a CT does not rule out anything. You may get there are cases, 25% of the cases initial CT scans may be normal.
So any advice will you give to the parents for this? Because they
So
may
I
be
think,
but
so in this case, we will tell the parents to observe the child. So if we think that the parents can, adhere to your advice, can do the monitoring, proper monitoring, and then obviously you can send them back and you can tell them if there is any excessive drowsiness or you see that the child is sleeping too much, if you are seeing any abnormal behavior, abnormal irritability, then they should come back. Otherwise, obviously they can see in the OPD in next 1 or 2 days.
okay. So I think we're clear on that. So for mild
And
TBI,
please, one more thing, very important thing. If you have a history of non-accidental injuries, like if you suspect there is a shaken baby syndrome or the atmosphere where you're going to send the child is suspicious, then you shouldn't be sending the child back to that place. Okay, sorry.
So this child, so as ma'am has said, so we'll just advise them that they can follow up. So as ma'am has already told this, I'll just mention that there are guidelines for this CT also, which helps us to guide. So this is a pediatric care network guidelines, which has given us some recommendation whether to do CT in the emergency or not, or can. So as ma'am already said, if the child is altered mental status, low GCS, and if there are signs of injury like a depressed skull fracture, then you have to do a CT. Otherwise, you can keep the child for observation if the mechanism of injury was not severe and the child looks okay. And for this was for less than 2 years. For more than 2 years, same findings. But if there are again signs of injury like basilar skull fracture, and if the symptoms are severe, then again you will decide on a case-to-case basis. So let's go in case. This was an 8-year-old child who was brought to us by the parents. The parents were traveling in a car and they lost control and the car went on and hit a pole. So here I think the mechanism of injury looks really significant. It's a high-speed motor vehicle accident. So as I already mentioned that this is a significant injury. So the child was to the emergency room. The child had loss of consciousness. He was unconscious on presentation, and the parents said that the child had 2 episodes of vomiting 30 minutes after the accident. After that, the child is drowsy but arousable and irritable, and he was complaining of headache for some time after this injury. And otherwise, he has just some bruised hands. But parents also mentioned that briefly the child had little stiffening of the hands, and there was like uprolling of the eyes. So that is what the parents noted for a brief second. But otherwise, when at this moment, the child was moving all his hands and limb, but he's still drowsy. So, Dr. Rashnav, what will be your management priorities in this child with this history? Dr. Rashna?
So if I look at this child, then there are certain red flags over here. If you look at it, loss of consciousness has not been timed how much it was. The
30
child
minutes.
is vomited twice. Drowsiness is persisting, while the child is arousable. Headache is there. Sorry.
No.
Then there is a brief stiffening of hand and uprolling of the eyes. I think that is one of the important red flag which is there. This child may have acquired more severe injury and has not manifested here. So here there are certain management priorities in such children. One is that we have to be careful about the cervical collar in such children. It is, since it was, if you look at the mechanism of injury, it was a very high speed of injury which has occurred in this child. So, taking care of the spine remains a priority. And then, obviously, you are going to look at the ABC of the child and is going to manage accordingly. So I think if I see at the slide, GCS I think has come down to 9. The pupils is still normal, and vitals are stable. Although there is a gurgling sound. Again, gurgling sound indicates that child may be not able to maintain the airway, and child may also had a episode of seizure. It looks like with the uprolling of eyeball, and so probably this is the time when we should take care of the maintain the airway, and we can intubate this. We have to place the cervical collar. We have to intubate by using a jaw thrust maneuver, and we have to maintain the vitals.
So exactly. As we had mentioned that this child presenting with a severe form of injury has come up in the golden time of management. So in all neurological head injuries, you have to be very aggressive in the initial 1 or 2 hours, because that is the time that will determine your final outcome. Because here the child has significant head injury, and to prevent secondary injuries, maybe because of hypoxia, or maybe if he has lost blood causing hypotension, or if the blood sugars were low, or if there any other injury, that is the time when the brain will be affected. So this time you have to be very aggressive. And as Mama said, yes, cervical collar is very important. Any trauma incident, you have to place the cervical collar, keep the head in the midline, stabilize it. You need a lot of help. Maybe 3 or 4 people has to be there protecting the airway, and then you need to intubate. So this is the child in the ER. The child was intubated with all neuroprotective care. The child was given a hypotonic saline bolus, and the child was given sedation and paralytic, and then we have proceeded with the intubation. So, ma'am, in this case, would you do a CT or MRI?
So I think ultimately we have to do a CT. Both CT at this stage, we have to do a CT to rule out any bleed or any midline shifts. Doing CT has got its advantage as a radiation, but MRI at this stage will not be very helpful. Both are complementary, but usually MRI is done later on to further study if the child is not improving or showing any worsening.
So, what are the indications for CT in this patient? I think we have already discussed.
Yeah.
So, some point for MRI, if we have time, the child, if he stabilizes, should we proceed for MRI immediately?
No, I think if in a sick child, we should do a CT and we should continue with our management. If the child does not improve, or if the child worsens, see, there are two indications. One is you have a normal CT and the child is not improving. Then you have to do MRI to look for any infarcts and everything. And then other is the case where the CT is where the CT is showing worsening and you have to take some, but there is no bleed. Then obviously you're going to do MRI to prognosticate the patient in cases of diffuse axonal injury and all. So initially we don't have to do a CT. Both are complementary. Both are not like, they are not alternative. We have to do CT in the beginning, and then later on we have to complement with the MRI study to look for brain conditions, look for ischemias, infarcts, look for diffuse axonal injuries, vasculitis. We have to do it.
Dr. Shashank, are you there?
Yes, sir.
So, so can you tell us what advantages MRI will have at this time, or maybe in the next few hours if we are planning? So should we do an MRI at this moment of time?
So, sir, right. As ma'am discussed, so first thing that we need to do in this patient is CT scan, because CT basically gives us critical information regarding the grade of injury to assess whether an emergent surgical intervention is needed or not. So initially, CT is something that has to be done. MRI, we usually reserve it for in later stages, especially if we talk about patients with mild to moderate TBI. So MRI can help us in showing small cortical contusions or small bleeds, microhemorrhages that can be missed on CT scan. So this is something that we do later on, and especially in severe TBI, like when there is shear injury, so there are chances of diffuse axonal injury. In that case, also CT won't show significant findings. So in that case, also we later on we go ahead with MRI that will show us linear and punctate foci of blooming on GRE sequences. But uh, rarely in mild to moderate TBI also, conventional MRI that we do that can appear normal. So in this setting, then we can go ahead with advanced neuroimaging techniques like functional MRI or diffusion tensor imaging or then MR spectroscopy. So these findings, these advanced MRI sequences can basically help us in studying the microstructural integrity of the white matter tracts or the functional aspect of the brain. So for example, if you see in the left upper image, this is the DTI, this is the tractography image that we obtained from the DTI. So we can see, so in this patient, the conventional MRI that was normal. There was nothing on flare or SWI sequence. But on tractography, we can see there are small defects in the white matter fibers. So these microstructural abnormalities can be shown with beautifully with help of DTI. So it can help in prognostication as well as follow-up of the patients. Now on the right side of the image, we see this is the functional MRI image. So we can see the in healthy controls on language stimulation. We can see there is activation of certain areas of the brain. So we see there is activation of bilateral Broca's area in the frontal lobe anteriorly, and in temporal lobes, these are the areas of auditory cortex that are getting activated in the normal healthy controls. But in patients with acute traumatic brain injury, we can see there is muted response. Only a small area of activation that we can see in left temporal region. But on follow-up, we can see there is little bit of resolution. We can see there is activation, larger activation on the left side and smaller areas of activation on the right side also. So again, a functional MRI can help in depicting the functional aspects of the brain injury. And these are the images in the lower image we can see. So these are GRE images. So in this, we can see there are linear and punctate foci of blooming that we see on GRE. So this is the typical case of diffuse axonal injury. So CT won't pick up these findings. So it is the flare and the GRE sequences, the SWI sequence that are quite helpful in depicting the DAI related changes.
Yes, sir. Thank you. So yeah, so as Dr. Shashank has mentioned, yes, so this DAI is a separate spectrum of patients with a very severe injury. And yes, this will not be picked up in your CT. So as ma'am also has said, a normal CT scan will not rule out your head injuries, especially if the child is not waking up after the trauma, prolonged loss of consciousness for 4 to 6 hours, not waking up. And with a bad CT, you should think about diffuse axonal injuries, and that will affect the outcome. So as we will see later on. So Dr. Shriram, again, we have done this.
Yeah,
So can you
so this is
mention?
the CT scan of the same patient.
Yeah, this child, the
So
trauma child.
right, the axial HCT image here shows this hyperdense bleed in the left parietal lobe, and surrounding that we can see hypodensity. So that hypodensity represents the myogenic edema surrounding the bleed. And besides that, we can see faint areas of hyperdensity in the right frontal as well as parietal region, depicting SH in the NCCT image itself. So minimal SH is also there. And midline shift, I think there is mild midline shift towards the right side. Uh, so how do we measure the midline shift? So we draw an imaginary line from the anterior attachment of the fox till the posterior attachment, and basically at the level of maximum displacement that we're able to see. And then from that imaginary line, we draw a perpendicular line till the maximum site of displacement, and we then measure the midline shift. Besides that, in this case, this is the VR image of the skull bones. We can see there's a fracture involving the parietal bone that is crossing the suture, the squamous suture, and again extending till the squamous part of the temporal bone. There appears to be mild sutural diastasis as well, involving the lambdoid suture in this case.
So this child was reported as having a significant IC bleed with the edema. Dr. Shashank, what are the other signs of moderate to severe
Right.
see in CT scans?
Right. So majority of the findings as we discussed that can be seen on NCCT image. So contusions can appear as small patchy areas of hyperdensity in cortical, subcortical location, and in the intervening brain parenchyma that will appear hypodense. So contusions can be well seen on NCCT. Then various extraaxial hemorrhages like SDH, EDH. So EDH is typically biconvex and doesn't cross the suture, whereas SDH is concavo-convex and they cross the suture, as you can see in this image. And usually in acute setting, obviously because the bleed is acute, it will appear as hyperdense on NCCT head. But whenever we see small hypodense areas within the hyperdense bleed, it may suggest that acute or active bleed is going on. So that can be a danger sign. So besides that, in any intraparenchymal hemorrhage that can be seen on CT, then edema can be seen in relation to the intraparenchymal bleed or contusions. The edema will ultimately lead to effacement of the sulcal spaces and again midline shift. So midline shift, as I've already discussed, how to measure it. Then CT, obviously, with the help of CT, we also can delineate what are the fracture size, different fracture types of fracture can be assessed. And diffuse axonal injury actually on CT becomes difficult to pick up, but if we change the window levels, we can find small, faint, punctate areas of hemorrhages, usually at the gray-white matter junction in relation to the corpus callosum as well as midbrain. So it's difficult to pick up on NCCT head, but yes, DA is something that, again, MRI is more sensitive in picking up DA-related findings.
Yeah. So CT will give us a lot of information, as Dr. Shashank has said. So subdural hemorrhage is like, as I've already mentioned, that this can increase also, so it can go on for a chronic time, whereas the EDH is more like in case of an acute trauma. So
Exactly.
that yes, so that also will help us to prognosticate also. So there are definite guidelines, the volume, how much volume of SDH, EDH is important, and when to drain them. So with that, Dr. Rohit, are you there? Dr. Rohit?
Yes, good afternoon.
Yeah. So sir, as in the cities, there is an SDH and a EDH is there. So when do you propose for like surgical management, or should we leave them, observe them? How to go about it, sir?
Well, first thing, good afternoon, everybody. First thing that we need to understand is that not all head injuries and not all bleeds are surgical. So we need to very carefully assess a patient clinically and radiologically. And it's a clinico-radiological correlation when we decide that which patient actually needs a surgical decompression. So definitely, GCS is one criteria, as you have spoken about, where we decide how severe is the head injury. Based on the GCS criteria, we label the head injury as mild, moderate, severe, which we have already discussed. Then comes the radiology. So speaking about the subdural hematomas and the extradural hematomas, so there are certain radiological criteria. Dr. Shashank, please correct me if I'm wrong. So in cases of a subdural hematoma, wherever there is a midline shift more than 5 millimeter, there is a diffuse cerebral edema, and the GCS is very low. In that case, we should consider for early decompression. And when it comes to the volume of extradural hematomas, the criteria which has been mentioned in the literature is about the volume of 30 cc in the supratentorial compartment and about 15 to 20 milliliters in the posterior fossa. So immaterial of the GCS of the patient, if the midline shift is more than 5 millimeter in case of a subdural hematoma, we should consider an early decompression. Also, like I said, it's a clinico-radiological correlation. So clinically, we need to look for the signs of raised ICP, the Cushing's triad, typically raised blood pressure, bradycardia, and irregular breathing. All those signs in presence of these radiological findings should be taken up for early decompression.
Thank you, sir. So the message is clear. If you have signs of raised ICP with the midline shifts and the GCS is not improving, then you can
More than 5.
consider surgical evacuation. So, Dr. Rashnath, can you tell me about the poor markers of moderate to severe TBI? What are the poor markers, prognostic markers? Dr. Rashnath?
Talking about moderate to severe TBI, if we look at a case, this case presented with us at a GCS which was not so low, and gradually the GCS worsened. So during observation, if there is fall in GCS of more than or equal to 2, then that means this child is worsening and we should intervene. The other markers are other parameters are like at the time of presentation, if the GCS is less than 10, and or you have a or you have unequal pupils, or if the child presented with seizures or went into status epilepticus, then if there are focal neurological deficits, or if there are any signs of raised ICP, in all such cases one has to be very careful. I think the most important thing one should see right at the admission is the GCS or fall in GCS, altered mental status. All these things tells us that there has been a significant injury in the brain parenchyma, and this child is going to be, is going to have a poor, is going to have a very difficult course in terms of brain involvement.
Ma'am, are there any like markers for ICP on the bedside? Because everyone doesn't have access to doing MRI or CT every time, cannot do it. So
Exactly. So I think this is very important. At present, like if I remember around 20 years back, the only marker which we had for looking into the brain was pupils. So we were so pertinent that pupils has to be monitored every hourly. Uh, Pupils plus, of course, if you look at the Cushing triad, which comes quite late, where you will have low heart rate and high blood pressures. But these all markers, pupillary changes, Cushing triad of bradycardia with hypertension is quite late. But now we have better markers since we all have ultrasound machines in our hospitals. Here, we can monitor the patient at the bedside by looking at the optic nerve sheath diameter by ultrasound. We can also do transcranial Dopplers. So, if we are going to, I'm not advocating over here about a single values of these modalities. Here, I am saying that if you're going to look at the trends, if you're going to look at the trends of ONSD, if you're going to look at your TCDs, if you keep on doing these modalities at the bedside, then you will be able to pick up the velocities and various indices to tell you whether the child is worsening or not. Since we are doing it regularly, we sometimes are able to intervene when we see that the child's TCD or ONSD is worsening. We do intervene and we see that it reverse. We have seen the reversal also. So today we have mainly three bedside monitoring modalities. One is pupils, the other is TCD and ONSD. Besides that, people have also started managing these patients by looking at ICP, by managing the cerebral perfusion pressure, and there is a partial pressure of oxygen in the brain. So when I talk about ICP is the gold standard the gold standard, which has been taken as a gold standard, against which all the other modalities are looked, whether how much they can be reliable. But a very important limitation of ICP is its invasiveness. And so I see it is not easy to put it is not, I'm sure that there are very less units who are putting ICP monitor right at the outset. The other important way of managing these patients are by managing the cerebral perfusion pressure. So usually what we consider as that intracranial pressure, which is any intracranial pressure which is less than 20 is fine. So we have to keep our maps on the higher side to maintain the cerebral perfusion pressure. So, I can continue to talk about ICP, CPP, and this partial pressure of oxygen in the brain. But in total, we should know what modalities we have, and we should try to monitor our patients by the modalities which we have. I think the clinical scenario remains very important. Hello?
Yeah.
Yeah, so can you just move the slide? So, when I talk about cerebral perfusion pressure, then we have to understand that what is happening in the brain. Brain is a very tight compartment, and it has a allotted space for blood, it has allotted space for CSF, and it has allotted space for parenchyma, and there is no space for anything else. Whenever injury happens, there is going to be a swelling, and this swelling is going to present or is going to cause a mass effect. And this mass effect will cause either, is going to either impinge on the blood compartment. And by impinging on the blood compartment, what it is going to do, because that is the only compartment which is compressible. So once it is going to impinge on it, there are chances there will be less blood flow, and this is how the intracranial pressure will rise. So, so that's the reason we talk about modalities to decrease the to decrease to decrease the metabolism of the brain, to decrease, how can we decrease the swelling. Here comes the role of various other modalities, like hyperosmolar agents. You have to keep the child in a midline, keep the child elevated. Whenever you're putting a cannula, you have to be careful that the neck vessels which are being used are going to create some resistance, so they should be well placed. Then you have to keep the child well hydrated. Otherwise, already the maps will go down. We have to maintain some mean arterial pressures so that some cerebral perfusion pressures are maintained. Then you have to keep your carbon dioxide in a normocarbia, that is somewhere between 35 to 40. Then you don't allow this your patient to rise their temperature, so you have to keep the temperature, normothermia you have to maintain. Then you have to, after maintaining this, you have to keep, that's the reason you intubate your patient, so that you are sedating and giving proper analgesia. So again, you are trying to control the metabolic rate. And if still there are issues, then you can paralyze the patient. Then there is a role of hyperosmolar therapy, by which we are trying to reduce the volume, by reduce the swelling, so that we are trying to decrease that mass effect on the brain. That is this is what we talk about first year and second year management of the brain, while we are managing these patients of moderate to severe. Then there is a, if you have still if still you have evidence of raised ICP, if you see that the child is seizuring, or if you see that the child is posturing, or if you see any Cushing triad, if you see ICP surges in the form of bradycardia or hypertension, then in such cases you can, if you have somehow, in some of the brain injuries, the neurosurgeon may end up putting extra ventricular drain. Then you can drain the CSF and decrease the volume, creating some space, again creating some space. So everything goes around creating some space for the swollen brain to adjust. And then you can further decrease the metabolism by giving barbiturates. And of course, in some cases, in few cases, we end up doing a decompressive craniotomy for these patients also.
So the message is clear. It is always the raised ICP which is the most important, and that is what we are trying to control. So as ma'am has already said, as the intracranial volume increases because of the bleed, there is no place for the brain to expand, and because the skull is a rigid structure, the pressure keeps on increasing as shown in this curve. And at the last will be the Cushing triad, where clinically you will see this. There is hypertension. Look at the blood pressures in this child, bradycardia. So don't wait for this hypertension bradycardia to come. This is the ultimate sign of coning of the brain, and the child can succumb within a few hours of this. So act early when the pressures are less. So this we've already discussed how to manage your ICP. Just to reiterate again, this is the crux of all. So you have decisions right in the OPD, sorry, right in the emergency, and this child might have come early, where you still have time to manage because it's a golden hour, or they might come out after a few hours. So what is our goal? Everything has to be managed according to this goal-directed care. That the oxygen level should be okay, the PCO2 should not be high, because hypercarbia will affect your cerebral metabolism and cerebral blood flow will increase, which can further increase your ICP. Blood pressures has to be normal for this age. ICP pressures has to be less than 20. If you are able to measure it, I'll come to that. And as ma'am already tells, the most important part is cerebral perfusion pressure, because as your ICP is increasing, the blood flow to the brain is reducing. So always target this CPP. Even in our ICU, I'm telling my fellows that always target the CPP. So if your cerebral perfusion pressure is maintained, then the outcomes of the brain are good. So there are guidelines for that also. Then using a hypertonic saline, a bolus we give because that will reduce your cerebral edema. So in that we are using hypertonic saline. So 3% saline is available with us. We use that and we target a sodium upward of up to 155. Don't ever use hypotonic fluids. No the half NS or half DNS. No hypotonic fluid should be used. Always use normal saline for these patients for all boluses. So sodium up to 155 you can easily maintain with these patients. And again, no fever should be there. No fever, and the blood glucose should also be normal. So nutrition is very important. So coming on to this case, as ma'am has already mentioned, neuromonitoring is very important. This child is sick. He cannot go for a CT scan or an MRI scan right now. So we have bedside tools for this. We do a lot of ultrasounds. Our fellows are also doing. They are all trained in that. Learning curve is not much. Easily it can be learned on the bedside. So first one is showing the optic nerve diameter, where this is the ultrasound of the orbit, and we look at the swelling in the optic nerve. So as your ICP increases, your CSF is displaced, your optic nerve tends to dilate. And this is what we are measuring with the help of the ultrasound. And beyond 5 millimeters after 1 year of age, it is very significant. So that tells us, yes, the ICP might be happening. Otherwise, the other things we have started doing this Dopplers also. So again, using the ultrasound, we can use a Doppler to look at the cerebral blood flow velocities. And again, if the velocities are very high or if they are very less, in both the cases, it means the brain is being affected. So with the help of these Doppler flows, we can understand whether ICP is happening or not. And in this particular child, this child, we were able to use an intraparenchymal catheter. We have inserted an intraparenchymal catheter bedside, and we have monitored the ICP. So the ICP value here, if you can read, it is 21, so which is on the higher side. So our target of ICP is less than 20 in whatever maneuvers we are doing. And lately we have started putting these EVD catheters. This is extraventricular drainage catheters, where after a burr hole, the catheter is placed directly inside the ventricles. So, Dr. Rohit, can you share some like experience with this? What do you think which is better, parenchymal or EVD, and how we are managing these child with the EVDs?
Well, this is a very excellent and a very debatable topic. These bedside tools are definitely the modern technologies and modern techniques to bedside monitor the ICP. But when it comes to head injury, I mean, this is the basic things I'm telling for the fellows and the students also, that whenever any patient sustains a head injury, there is a primary injury which happens due to direct impact, and then there is a secondary damage which happens due to hypoxia, raised ICP, and free radical damage. So always remember, the secondary brain damage is more dangerous than the primary brain injury. So the goal of prevention, the goal of treatment of any head injury patient is to prevent a secondary brain damage rather than a primary brain damage. So like I said, the window period is very short, the time interval is very short, and we have to decide, we have to make a quick decision. Good thing about the head injury in children is that the brain plasticity in children is fantastic. Plasticity is nothing but the tendency of a brain to rewire its circuits and recover very quickly. So in children and even in adults, as surgeons, we keep a very low threshold. We say, when in doubt, take it out, which means that you should always keep a very low threshold for a decompressive hemicraniectomy or evacuation of the hematomas. But yes, there are certain conditions that we face, like in case of a diffuse axonal injury patient, like Dr. Naresh spoke about earlier. So in DAI, the radiological findings are not very characteristic. Sometimes the patient is so sick that you are unable to move the patient again and again for a CT scan or for an MRI. And even the CT scan shows very punctate bleeds and diffuse cerebral edema. And you always have a doubt whether you should actually go for a decompressive craniectomy on one side or both sides, or you should go for the surgery or not. In such cases, these devices play a very vital role. And like Dr. Naresh has very beautifully explained about the indications and the usage of all these bedside equipment, The only thing that I want to talk about here is the EVD catheter and the intraparenchymal device which we use for ICP monitoring. More than the benefits, I think there are a lot of challenges putting and using these devices. So for putting an external ventricular drainage catheter, the ventricles have to be dilated. In most cases of diffuse axonal injury, because of a diffuse cerebral edema, the ventricles are very small. Ventricles are chinked in size. So it's very difficult to cannulate surgically that ventricle. So chances of you doing multiple punctures, because it's a blind procedure, and then the chances of damaging the parenchyma are even higher. And the problem with the intraparenchymal catheters is that the chances of misplacement, chances of forming an intracerebral hematoma are very, very high. So between the two of them, EVD catheter is definitely a much better option compared to the intraparenchymal device. So again, I do not prefer relying much on these devices only in cases where there's an extreme, improbability of getting a CT scan done, or whenever there is a doubt. I prefer doing ICP monitoring. However, it is like I said, keep a very low threshold for doing a decompressive craniectomy, and that is how it has to be. Are you there, Dr. Naresh?
Yeah. So yes, sir has nicely mentioned. Yes, these devices have to be judiciously. So we don't use them in all the patients. There are very strict indications of ICP monitoring. So if you have like a prolonged PCS, abnormal CT, and if the child is worsening, then yes, you can do it. But then again, there are caveats for this. And I like to mention that even when I did a literature review, there is no direct mortality benefit with these devices. It's not like if you put the devices, you're going to save the child. But yes, it will reduce your ICP spikes, and that will improve your chances of managing the child better with the less of hospital stay, less of infections, and probably the cost benefit is there. But yes, the device are itself very costly, so it has to be used judiciously in all the children. It has to be decided. So we have, thanks to Dr. Rohit, we always talk to each other, and then we take a call whether it is required or not. So in this particular case, we are also doing continuous EEG monitoring. Here, the child on EEG, you see that the child did not have any further spikes, and the ICP I showed you before that Cushing's slide on that monitor. Now there was no signs of acute ICP. So probably that was a single episode of ICP settled with my neuroprotective care, sedation, analgesia, ventilation, and we did not need to escalate the therapy further. And the child improved, and the child was extubated after 5 days. So coming on to my last case, this was a 4-month-old female baby, and the child was traveling with his parents on a motorcycle when the child accidentally fell from the motorcycle. This child had a prolonged loss of consciousness. This child actually went to another hospital and then came to us. So the child was already unconscious for last 3 to 4 hours, and there was history of abnormal body movements, which were like seizure-like episode, multiple episodes, 3 episodes in 1 hour. And the child was dull, not moving much, and there was a pulling of eyes, there was stiffening of the hands, and then the child was brought to us. So here the golden hour had already passed by. So a lot of secondary injuries might have happened, and the child came to us. When the child came, the vitals were okay, blood pressures were fine, but sats were a little low because of the airway was threatened. But the GCS had dropped to just 7, and the pupils were unequal. So that's a very important clinical signs. Pupils are unequal, and there was paucity of movements on the left side, and the child was posturing. So we managed the child in the emergency. Neuroprotective care was given, mannitol bolus was given, and the child was intubated. And we have loaded the child with the anti-seizure medications. So phenytoin and levira were required. Multiple doses were required, in fact, over the next 2 hours. And then we have taken the child for a urgent CT scan. So Dr. Shashank?
Yes. So this NCT head shows diffuse hypodensity. On the right image, if we see, there is diffuse hypodensity involving the right cerebral hemisphere. So it is involving the right ACA territory, MC, as well as the right PCA territory. On the left side image, again, we can see the hypodensity on the right side, and on contrast, this cerebellar cortex is appearing quite bright. So there is insult to the right cerebral hemisphere. So this is basically both involving the anterior as well as posterior circulation. So this is possible if there is vascular injury or thrombus in the right ICA as well as right PCA. Or the second scenario is if there is presence of fetal PCA. If the PCA is directly arising from ICS, in that scenario also, injury to the isolated injury to ICA can lead to infarct in both the anterior as well as posterior circulation. So basically, there's suggests a diffuse right-sided injury, cytotoxic injury.
Okay. So this child had also other injuries, multi-system injury. He had lung conditions. So there were hyperdensities inside the lung. And again, in this child, as we were routinely doing ultrasound for the of the eye for the optic nerve diameter, we found that there was a retinal bleed also. So this hyperintense lining, it's actually the retina which has been detached, and there is subretinal bleed in this child. So we have multi-specialty team of neurosurgeons, neurologists, ophthalmic surgeons, everybody was involved in this particular case. So again, we have managed the ICP, as Dr. Rashna has already said, and all monitoring was going on. We were doing EEGs. We can see the EEG is very turbulent, so it was showing a persistent seizures. We were doing Doppler. The Doppler was again showing features of raised ICP, and the optic nerve diameter was dilated here. So all was pointing to a very severe acute ICP surges, and this was the child. And you can notice something on the head. It's written as no bone flap. So we have actually done a decompressive craniectomy for this. So this was within 24 hours that the child was taken off for surgery. So thanks to our neurosurgical team. So Dr. Rohit, please some points about decompressive craniectomy. I think we've already spoken, but can you clarify further, like which patient should be taken for decompressive craniectomy immediately, or we can
Yes.
wait?
Yes, like I said, whenever like I've already spoken about, whenever any patient comes to us with a very poor GCS in a severe head injury in the range of 3 to 8, whenever clinically there is a pupillary anisocoria, there is hypertension, there is bradycardia, there is irregular breathing. Like I said, there is a history of unconsciousness, history of seizures. All these become a clinical indication that yes, something is wrong. And if at all we are able to get a basic CT scan, which takes less than 30 seconds, that is the best. So the CT scan will give you all the clear images. Like in this case, you had shown the picture. The child is having a diffuse cerebral edema and a midline shift towards the left side. And already, I think the PCA and the ACA infarcts have set in. So already the coning had started in this case. So in such children, in such patients, we should always keep the threshold very, very low and just immediately take up the patient for a decompressive hemicraniectomy. So like in this CT scan, Dr. Naresh, can you please again go back to the CT scan? So if we have a look at the CT scan, we see intraparenchymal, there is hardly any bleed or any contusion or any subdural hematoma or the extradural hematoma, as you can see. However, if you see the right side of the brain, the sulci and the gari are totally effaced. We can hardly make out the sulci and the gari. Also, if you see the occipital area, there is a hypodensity, which is suggestive of infarct in the occipital area, which means the PCA, the posterior cerebral artery, has already gone under pressure, which is a sign of tentorial herniation. Means the middle temporal of the uncus has already herniated and compressed the posterior cerebral artery. So this is a grave sign. And already you had mentioned that the pupils were dilated, which means the third nerve is also getting compressed. So in such case, we should not waste any time in taking the patient up for a hemicraniectomy. So sooner the better. And the sooner we take the patient up for the surgery, sooner we prevent the secondary damage. And once we take up such patients for the surgery, I've seen the pupils reverting and the other conditions reverting. So Dr. Naresh would tell you about the further course of the clinical course of this child again.
Yes, so we are very thankful, sir, for taking this child for decompressive, and looking at that CT scan, we were very scared, and we had given the parents a poor outcome, and there was always we are thinking a possibility of diffuse axonal injury, as I have spoken before. So with that consideration, the prognosis was guarded for this child, but then again we intensified the therapy, again aggressive therapy for this child. We went up to tier 2 and tier 3. Decompression has already been done. Deep sedation is there. Anesthesia is there. The child has been paralyzed so that anything which raises the ICP is avoided. Then we go to tier 3 where we give them barbiturate coma. So we use thiopentone in this child. We give pulses of thiopentone and then give a continuous infusion, and we deeply sedate the child, and then we do a continuous EEG monitoring also. So that is very important. So there should not be any seizures, because it with all that paralysis, with all that deep sedation, there will not be any clinical seizures, but the child might be having non-convulsive status epilepticus, which might be going inside, which you will better manage if you have continuous EEG and bedside Doppler also. With that, we can make out that yes, something is not going well. So we intensified the therapy, went on to barbiturate coma, and transiently we also use hypothermia of these cells. So if you go on to read the Brain Trauma Foundation guidelines, they have given this tired approach. So we went up to tier 3, and we did maximally what we could. Then decompression was done. So with that, this was the CT scan. You can see how the brain herniates. Is herniating on the right side, and we were just hoping that the child survives, because first 24 hours are very critical in this case. But with the I think it was by God's grace that we were able to save this child. So everything was managed. ICP surges reduced with our monitoring, and but the child, obviously, the much injury will be quite a prolonged stay. So in this cases, nutrition is very, very important. Establishing a feed is very, very important. So because you have to give very high calories, very high proteins, so that also be taken care of. Then there are chances of infections. Every infection setback that can lead to worsening of neurological outcomes. That has to be taken care of. Then prolonged ventilation, then that has to be taken care of. With the tracheostomy has to be done. And with all these things, they will have a lot of withdrawal phenomena when they come out of this sedation. So it is to show here, it looks that the child decompression was done and the child was managed, but then it took almost 5 weeks for this child to stabilize. But then we were able to discharge the child on oral feeds, on tracheostomy, and I think that was a big achievement by the multi-speciality work which we were able to provide to this child. So coming on to the last part of this talk, outcomes. So Dr. Rajni, are you there?
Yes, I'm there.
So, ma'am, since you follow these patients for a long time, so like, you tell us how are these child behaving in the long-term outcomes?
So it depends on the extent of injury. So if the child has diffuse axonal injury or a severe TBI, then definitely the prognosis is going to be little grave compared to mild TBI. So when we speak about severe TBI, there are three things that we counsel to the patient. One is about physical disability. Second is about mental disability, that is about cognitive dysfunction. And along with that, vision and hearing, that has to be followed and checked. And the third important thing is epilepsy. So there can be any variation between these, like the severity of physical disability can be more than a cognitive dysfunction or epilepsy. Or some kids, they don't have any physical or mental issues, but then they might have only epilepsy, chronic epilepsy syndrome. So what we do in a OPD usually is first do rehabilitation of the kids, put them on seizure medicine, and then follow. And if we feel that yes, the child is improving or not. So after 3 months, we do a repeat scan to get an assessment of the permanent gliosis. So if there is any injury, and after 3 months you feel that there is a gliotic change, that is a permanent thing, and then we prognosticate that yes, this is going to be lifelong. Initially, I have seen lot of improvement within first 3 months because the child has a lot of neuroplasticity. So if good rehab is done, good nutrition is done, and they are put on good seizure medicines, so kind of a good rehabilitation program can lead to a better outcome. And the early you start. As in our ICU, we all follow the policy of rehabilitation right in the ICU as soon as the child is stable. So we involve our physiotherapist, we do a good nutritional rehab. So that actually helps in a good rehabilitation. So the mixture of findings which I said about the physical disability, cognitive dysfunction, epilepsy, vision, hearing, these are the things which we follow in our OPD.
So yes, so I was already mentioned that yes, so this is a combined team effort for managing these patients. Acute management will save the child, but then these kids have long-term morbidities. Severe the injury, especially the DAI, they will take longer time to recover. Mild TBI can recover in few days or a week, and they are on oral diet. But the severe ones are the one which will be suffering the most. because the sensory may not be good. They're on tracheostomy. They will have a lot of feeding issues. They will have a lot of post-traumatic disorders, stress disorders. So that all that has to be managed, and it begins right from the ICU. We start. So Dr. Rajni and us and the OTPT teams are all always the bedside so that the child improves with a good functional outcome. So that is the thing. So Dr. Rajni,
Yes.
do you think like the long-term epilepsy is prevented, like if you have treated this child with good anti-epileptics now, because we see that sometimes they require more continuous anti-epileptics. So do it prevents the long-term epilepsy in these children?
Yes, yes. See, the idea is about neuroprotection. So what happens in the acute stage, if we do a EEG monitoring, that is how we do. If the child doesn't gain a good sensorium, immediately after we do a repeated EEG monitoring. And in our ICU, as we all follow, we do continuous EEG monitoring also. So that will help us to treat any epileptic discharges at the earliest and ultimately protecting the brain. So the more you protect the brain, ultimately the outcome will be better. So that is our acute management. Basically, what you're talking about is acute management. Monitoring the discharges, treating them well, and getting a good neuroprotection at that acute stage will definitely lead to will change the trajectory. If the child was a severe TBI, but still we have seen kids having good prognosis and with minimal epilepsy, like controlled epilepsy, not a refractory epileptic encephalopathy ones.
Yes, yes. So that was the message that and despite anti-epileptics, the child may get seizures later on also.
Yes.
So just to summarize some take-home pearls. So all these patients which I have presented, I think the stress was mostly on the neuroprotection because ICP is real. It happens in all the patients right from the time of presentation, and that is an emergency. Any child who is not gaining consciousness, who is posturing in front of you, who has hypertension ready, that means the child is having ICP and that has to be managed. And this child can collapse in the emergency while intubating if you don't take proper measures. Keep a mannitol ready, keep hypertonic saline ready, deep sedation, okay, with opioids like fentanyl and paralytic agents. Use a lignocaine to reduce all the reflexes, oral reflexes, and then only you proceed for intubation of this child because ICP can kill the child in that scene. So another important point is that CT scan, as already Dr. Shashank said, that normal CT scan will not rule out a head injury. So don't be just content with that the CT is normal. The child may deteriorate later also. Goal-directed care, as I had mentioned, of the targets of your CO2, O2, sodium, CPP is very, very important. So goal-directed care is very, very important. So don't just go on intubating a hypotensive child. At that moment of time, you might require a fluid bolus. You might need to start the child on inotropes. Then only you have to proceed. So hypertension is very bad for brain. So keep everything ready. Keep an adrenaline ready. Keep a NORAD ready. You have to maintain your CPP. For that CPP, you need proper hemodynamics. So if the blood pressures are low, use inotrope judiciously. And aggressive therapy will save your patients and it will have a lasting outcomes. Uh, there is no role of steroids in these patients for acute ICP. Maybe for tumor-related edema, yes, it can be, but otherwise in our patients, even in PICUs, there is no role of steroid. You might actually land up in secondary infections, but so don't use steroids. There is no prophylactic role of antibiotics in maybe like mild to moderate TBI, but yes, if it's a multi-system involvement, so you might want to give a prophylaxis as per your hospital policy. For seizure prophylaxis, there is no choice, but yes, phenytoin is what everybody is using, and just a short course of phenytoin, maybe for 7 days, is enough in mild to moderate. But depending upon your particular case, if there are persistent discharges, you feel the child is has worsened, then you might need to give a longer anti-epileptics. And with all this, a good dedicated multi-speciality team comprising of PICU, neurosurgery, neurology will go a long way in improving the outcomes because I already mentioned it is a golden hour where you have to manage these child. So having everyone there at the right moment will save the child. And don't forget about the families. It's a very stressful condition for the family. So always involve the family in the discussion process. And we have seen such good outcomes of children if the parents were involved early and if they were confident of managing the child. So they take the child on tracheostomy for months we have sent the child on a tracheostomy, like for 3 months, 6 months, and the families have been very cooperative, and those kids have really improved and justified our work initially. So thank you everyone for patient listening.
Thank you, Dr. Naresh, for such a detailed and insightful presentation. You have very well outlined how a multidisciplinary care can improve the outcomes for the patient. I don't see any questions in the chat box, but if the participants have any questions, they can unmute themselves and ask. Meanwhile, we know that pediatricians are often the point of first contact. So I would request Dr. Rachna, followed by Dr. Rohit, to quickly share a few pearls for the pediatricians as a point of first contact when dealing with a child with brain trauma, head trauma. Rachna ma'am, are you there?
No, I don't think.
Dr. Rohit, meanwhile, you can share your few points.
Like, yeah, just a moment. Yeah, can you hear me?
Yes, sir.
Yeah. So, like Dr. Naresh very, very nicely said that it's a teamwork. Definitely, everybody has their own role to play in this, and all of us should work in a close cohesion to treat the patients with head injury, particularly the children. And the most important thing that I would want to tell you is that the treatment of the head injury should be aggressive. Like Dr. Naresh also pointed out in his last slide, we have to be very, very aggressive. And good thing is that the plasticity, the neuroplasticity of the children's brain is very good. So in case we diagnose the problem on time, we intervene on time, and then we do a post surgery and a post head injury management, that is the secondary brain injury prevention, then we can really work wonders to towards the outcomes.
Thank you so much, sir. So we have come to the closure of this session. Thank you, Dr. Naresh, for such a good discussion. And special thank you to all our panelists, Dr. Rachna ma'am, Dr. Rohit, Dr. Shashank, and Dr. Rajni, for taking out your valuable time and sharing your expertise with us here. And I'm sure the attendees are definitely wise as to manage a patient with head trauma. So next month, we will be back with another interesting session in BLK Telepates. Till then, thank you very much.
Thank you.